Bismillah ar-Rahman ar-Rahim. Pulmonary embolism in pregnancy. Pulmonary embolism in pregnancy should be managed as in the non-pregnant patient, although the pulmonary embolism severity index score is not validated, so the decision about outpatient management should be made in the consultation with an obstetrician. The incidence of DVT plus or minus pulmonary embolism in pregnancy is 1 in 1,000, and the risk of pulmonary embolism in pregnancy is greater with increasing maternal age and with increasing gestational age. And more pulmonary embolisms occurs during pregnancy than after delivery. There is a 20 to 30 times increased risk with cesarean section compared with normal vaginal delivery. Pulmonary embolism is one of the commonest causes of maternal death in pregnancy. 1 in 100,000 pregnancies. D-dimer is raised in normal pregnancy, and so it is unhelpful in the investigation of thromboembolic disease unless negative. The CTPA whole body radiation dose is 2 to 4 mgy with an absorbed dose to the fetus of 1 of 0.01 mcv. This equates to a risk of fatal cancer to age 15 of below 1 in 1 million. The absorbed dose to breast is 10 mcv, higher in pregnancy, and CTPA increase the lifetime breast cancer risk in premenopausal women from 10% to 11.4%, with an even higher risk in pregnancy. The VQ scan whole body radiation dose is 1.5 to 2 mgy, with an absorbed dose to the fetus of 0.12 mcv. This equates to risk of fetal cancer to age of 15 of 1 in 280,000. The absorbed dose to the breast is 0.28 mcv. A half dose perfusion can reduce the radiation dose further. The overall radiation risk depends on the gestation of the fetus and the metabolic activity of pregnant breast tissue. There is considerable debate as to which imaging technique is best in pregnancy in terms of radiation risk to both the mother, including the breast tissue, and the fetus. The lowest overall risk favors a Q scan as the first line investigation, especially as this young healthy population are likely to have normal lungs. Some experts suggest a leg ultrasound first. In those with antenatal thromboembolic disease, low molecular weight heparin is used. Close to the delivery, this is changed to unfractionated heparin, as it is easier to monitor and to reverse its effects. It's unclear whether heparin should be stopped or the dose reduced at the time of delivery. Low molecular weight heparin levels can be monitored with factor anti-10A levels. There are case reports of successful thrombolysis, catheter-directed thrombolysis, and embolectomy in massive pulmonary embolism, but no relevant trials. Warfarin is teratogenic and is contraindicated in pregnancy, although it's safe in breastfeeding. Direct oral anticoagulants are not licensed. Anticoagulation should be continued for 6 weeks after delivery or 3 months following the initial episode, whichever is longer. Thromboembolic disease and oral contraceptive pills. Estrogen containing oral contraceptive pills pregnancy increase the risk of pulmonary embolism, but the incidence of fatal PE is low, estimated of 1 in 100,000 oral contraceptive pills users with a median age of 29. Risk of fetal pulmonary embolism is twice as high in those taking third generation pills. Previous history of DVT or pulmonary embolism is a contraindication to the oral contraceptive pills. That's all. Thank you.